Hello, ladies and gentlemen. Elvis?
Hi.
Yeah, over to you, please.
Hi, welcome everybody, and welcome Dr. Muna for being here again today as always. Welcome to Stefan Bieng, Emmanuel, Dogima Mofo, Bryan, Theodore, Bryan Guana, and all those I can see on the first screen. I'm welcoming everybody to this edition of the Cameroon Town Hall for Healthcare Professionals. We have come back to one of those subjects that was the main reason for which the town hall even came about, which is COVID-19. And so it's a very relaxed session today, coming back home, as I can put it. And I hope we are going to really enjoy the conversation. We are going to be moderating the session today, myself and Dr. Bryan Tegomoh, and hopefully we're going to also have Dr. Kate and Dr. Christelle, who will be joining us shortly. So once again, you're welcome to this edition of the Cameroon Town Hall. We are just 9 persons now that have joined directly online here. But remember, the session is being streamed on Facebook, and hopefully we'll have other people join on the other platforms. And before we get to start the conversation, let me just say hello and do a round with the moderator. Hello, Dr. Bryan. How's it been?
Yeah, thanks, Elvis. It's been an interesting week. Yeah, it's great. It's always great to be back and to have these conversations again. I know we are all tired. I, in particular, am very, very tired and exhausted about COVID. And it's very unfortunate that we still have to have these conversations about recent developments on COVID. So, yeah, looking forward to the session.
Yeah, hopefully at some point in time, you know how things change. At first, when you went out without a mask, you were looking like someone who was abnormal. Now, when you go out with a mask, you look like you're abnormal. So at any point in time, things change and make us look abnormal. I took a bus the other day from New Jersey to New York, and in the bus, I was the only person with a mask. I had to remove it and say, hey, what am I doing? So, but that's just to say that we are kind of in a roller coaster situation, and it's right now, it's important for us to talk about it because the cases are resurfacing, and I'm sure you guys are always the best when it comes to updates on this kind of a subject matter. Hello, Dr. Muna. Welcome to the session.
Elvis, thank you very much. You made a wonderful statement. The other day, I just got to realize that all my patients, my cancer patients coming in, 50% of them are putting on masks. You get this whole political divide in ideology. Everyone is realizing the cases are surfacing, and we're having new cases of hospitalizations in the US and in different states happening now. And you get the ideological divide is already there. Those who believe that masks actually did help them and is going to help their families, they're coming with masks. Those who don't are there questioning those who are putting on masks. Even healthcare workers are also in the habit of questioning. But I think we have reached a point where today is going to be a very interesting and enlightening day for us to have a discussion. And we're into, I think, the 3rd year of this, Bryan, and the 3rd year and some months, and we'd see how much we know. So our discussion today will be led by Dr. Bryan Tegomoh, and we're going to just follow the lead because he's been one of the gurus, I'll put it that way. He has a lot of publications in COVID and has been following this and works with the CDC, though he's not talking here under the auspices of the CDC, but he's one person whom I know is super up to date. I used to be up to date with COVID, but I got carried away with my regular day-to-day job, which is oncology. So I'm a bit in the background, and I'll be the one asking questions today. So yeah, Elvis.
Yeah, really interesting because, you know, at some point in time, there was each time I'm attending any session and I just hear the word genetic sequencing, Bryan's image just comes to my mind because I was like, this is the guy, when you talk about this subject matter, he was really on top of the happenings around Africa. And there is so much work he has done in training and just making sure that most of the countries are able to, you know, prepare themselves to even identify their own new variants. And so he's done a lot of work in that domain. We're going to hand over the floor to Dr. Bryan to do a presentation, and then thereafter we're going to have an interaction. I don't need to introduce him, he's your co-moderator, you see him every day, so over to you, Bryan.
Yeah, thanks, Elvis. And just to confirm that you can see my slides.
Yes.
Yes, we can see your slides.
Yeah, awesome. Yeah, thanks a lot, Dr. Mono, and really great. Thanks a lot for your leadership in leading this effort for the last 3 years. Every time I go into any public gathering where there are Cameroonians, they always meet me and they tell me that they so much appreciate what the town hall has done in terms of advocacy, in terms of COVID-19 and healthcare awareness back home. So I really want to appreciate you as well, and the chair and Elvis as well, for your leadership in ensuring that this vision stays. So today we will be talking about COVID-19, the updates, and this is a subject that has been I think many of us, including myself, has been exhausted by COVID, and it's very unfortunate that we find ourselves again in a situation where we have to discuss about COVID. On the April the 27th, 2022, the UK and the European CDC declared a state of endemicity for COVID-19. And this was because the rates of COVID-19 hospitalizations and deaths has sort of equaled the levels for RSV and influenza for that region and for that period of the time. Just a few months ago, on the 5th of May 2023, the director of the World Health Organization, Dr. Tedros, declared the end of the public health emergency of international concern. That was a remarkable time, but it took him about 1 year after the European CDC and the UK had declared the end of their own public health emergency. Here in the United States, where I am, and the president declared the end of the public health emergency on May the 11th of 2023. So you can see there's lots of public health agencies from across the world that have sort of come to terms with, accepting a state of endemicity for COVID and things like that. So we're gonna discuss a little bit about what that means today. But I want to remind everyone that COVID is still ongoing. And it's still important to stay vigilant. We are currently experiencing rising numbers of cases, particularly with the new variant called EG.1.5 that seems to have been rising in many places due to the evasion of our immune system and things like that. And also, you may have heard lately, Dr. Mono, about the new variant called BA.2.86 as well, that has significant mutations on top of the spike protein, an unusual accumulation of mutation in a very short period of time. So, and also there are concerns around long COVID. It's not just about the acute infection that comes with getting COVID, but also the long-term consequences or the long-term sequelae of those, which I think we have not really been talking a lot about. But there are lots of people who have lingering symptoms of COVID-19 that surpasses their acute infection, whether it's brain fog, or it's respiratory difficulties, not being able to do tasks that they used to be able to do before. So it's an important subject to discuss. I think it's important for us to keep this in our radar, even as we move out of this phase of the acute phase of the pandemic into a state of somewhat endemicity. We have our radar on the constant evolution of cases and emerging variants. We are tracking this consistently, epidemiological metrics, etc., and things like that. Before I continue my presentation, I just want to highlight here that all the opinions I'll be sharing today are my personal views. They do not in any way represent the views of my employee. So last week there was a headlines from the New York Times that stated that the pandemic is not over. It's not over yet. That as the late summer COVID wave brings a it brings a warning of more to come. So hospitalizations were still very low, but there's been some modeling that has suggested that we might be seeing a rise in COVID-19 hospitalizations as we delve more and more into the fall. So this was a highlight from the New York Times article that just came out last week. On this graph, you're seeing a graphic from the World Health Organization. This is some sort of a dashboard that reflects the epidemic curve for cases across the world for COVID-19. So on the left, you have the distribution by WHO region. You have the European region. You have the Western Pacific, the Americas, the Southeast Asia, Eastern Mediterranean, etc. And you can see we've kind of been seeing this rise and spike in cases. And this color you're seeing right here in magenta, or would I say purple, is mostly represented by China. And you might remember in late December 2022, the Chinese government decided to suddenly lift their COVID-19 restriction, public health restriction out of a sudden. And I think this was a little bit, as a lot of people in the scientific community has highlighted, we think this was a little bit premature at a time when they had not yet achieved a certain level of herd or community immunity or herd immunity. They didn't have most of their elders being appropriately vaccinated. So I think that led to the surge that you're seeing right here in early January 2022. And most of those colors, most of the cases you will be seeing still are mostly from mainland China. I just want to highlight on this slide that America is not very much represented here because the US stopped reporting individual cases just several weeks ago. So the Americas are not represented in this slide. So that's one thing you should take note. Reporting individual cases to the World Health Organization, that stopped a few weeks ago. And we'll talk a little bit about the meaning of case counts at this stage of the pandemic. This is a graphic that just overlays the COVID-19 deaths and COVID incident cases since here is from 2019 to 2023, and the slide below shows the levels for the last several weeks. So this is a rolling average. The black line represents the sort of like the rolling average for the 28-day interval for COVID-19 incident cases, and you can see the deaths has actually been decreasing quite significantly. We're going to talk a little bit about the meaning of that and the difference between deaths and hospitalizations and interpreting those values as we evolve more and more into the pandemic. But you can see right here the level of still the Western Pacific has been kind of hyper amplified on this slide as well. And this is again cases mainly from mainland China, and we think it's mostly because of the fact that they just suddenly lifted their public health restriction without proper preparation and things like that. So that's been some of the hypotheses that has been highlighted. This graphic I took from the World Health Organization's website, the dashboard showing the percentage change in confirmed COVID-19 cases from across the world. You can see COVID-19 cases across Africa has kind of been in that narrow range between -10% and 10%, sort of not a lot of change that we are seeing there, but you can see the massive amount of change is still, again, happening in that mainland China area. We've had some significant change in other parts of Africa as well. Here we have the percentage change in confirmed COVID-19 deaths for the last 28 days as well, showing those deaths again still rising, in particular in the Western Pacific. This graph here shows the weekly COVID-19 hospitalizations, and you can see if you look closely here, you'll see that levels of COVID-19 hospitalizations have been rising quite slowly, and these are not just COVID-19. These are not just people who, like, if you go to a hospital and you're going for a hip replacement and you get screened for COVID and you're found to be positive for COVID and it's being reported as COVID. No, these are actual hospitalizations that are as a result of COVID-19, the COVID-19 infection itself. So this excludes people who've been admitted for different reasons or coming for screening or being hospitalized for different things. So that's one point I wanted to highlight. In Cameroon, we haven't really had a significant change in terms of our reporting. There's just been not as much data has been coming out of Cameroon. So the last time we really had or experienced a surge that was quite a little bit significant was just in late 2020, late 2021, early 2022. That's when we really had increase in the number of reporting. But lately, we really haven't had our surveillance being on point. So we don't have as much surveillance data coming out or being reported in our country. So we don't really have a really good metric to say what the state of the local pandemic is. And maybe we'll talk a little bit about the meaning of surveillance at this point of the pandemic. Are case counts meaningful? Is counting clinical cases relevant at this stage of the pandemic? This is a figure I just got from the CDC MMWR. The weekly report from the CDC that estimates the crude mortality for COVID-19 throughout the pandemic. What they tried to do here was to assess the risk of severe COVID-19 hospitalization during the different waves of the epidemic. And you can see, this is probably the alpha wave. So between late December, early February, when we were, which was primarily characterized by the alpha wave. Here we have the delta wave, and we have the early Omicron and the later Omicron. One of the key things, the summaries of this particular study was the significant decrease in hospital mortality among patients hospitalized for COVID, how that number increased or decreased from during the Delta wave from about approximately 15.1 or 15 to 16% to approximately 4.9% during the later stages of the Omicron variant. What's accounting for that decrease in hospitalizations? Is it increase in vaccination? Is it increase in more early treatments being available? Is it more appropriate pharmaceutical measures? Is it other public health interventions? Is it just rising herd immunity, whether it's gathered from infection or it's gathered from vaccination? But the levels of immunity has been decreasing during the Omicron wave. But also there's been lots of other studies that have demonstrated that the Omicron variant causes much less severe than we had previously seen with other variants like beta or gamma and things like that. So that has kind of changed or decreased in the last several weeks. Now, counting cases has become a little. We've lost, I would say, the ability or our ability to count cases. And there's not enough testing for electronic lab reporting, not only in the United States, but globally. One of the things that we have replaced our case count with is wastewater. And how does COVID get into wastewater? If you have COVID and you swallow your respiratory secretions, you might expel it as a fecal matter, and that concentration of SARS-CoV-2 can be quantified in the fecal matter. That's in treatment plans, and that's how we sort of have a sense of what's happening within a community level. So this is a graphic that shows the number of treatment plants. This is specifically for the United States, and the rest of the world is a little bit lagging behind in terms of wastewater surveillance and even making sense of how to use wastewater in routine surveillance, epidemiological surveillance purposes is still a very big challenge that we still have to work around. But here really highlight some of the treatment plants, the wastewater treatment plants from across the United States, and showing where most of those treatment plants are arising. And you can collect samples from these sewage sites and actually measure the quantity of SARS-CoV-2 within the level of SARS-CoV-2 within the samples and have a really good estimate of what might be happening in the community. But again, this is wastewater samples. It's not controlled for the population. It's not controlled for, there's a lot of, there's a variety of factors that could influence what the level of SARS-CoV-2 that you might be able to measure from wastewater. But again, this technology or this new innovative technique is being implemented for other things as well, like tracking antimicrobial resistant genes, tracking monkeypox, tracking polio. So the possibilities and the applications of wastewater is extremely broad, and it also comes with a lot of other challenges in terms of how do we make meaning, how do we standardize the methods used to control for these different wastewater levels. But I think in Africa and in particular in Cameroon, we need to make some progress in terms of building wastewater treatment plants. This is a graph I took from the Africa Development Bank Atlas of Africa Wastewater. And here they try to show what the state of wastewater treatment plants is across the world. But in particular in Africa, you can see Africa is really lagging behind in terms of having wastewater sites and wastewater treatment sites and sanitation plants. So we are significantly behind compared to the rest of the world. So we still have a long way. You can also see the Oceania as well. There's a lot of gaps in terms of wastewater treatment plants and stuff. So it's very difficult for us to use wastewater in our own setting to track pathogens. But I think it might be a very useful indicator for epidemic and pandemic preparedness as we move on in the pandemic. So a lot of work still needs to be done in that area. And this is a sort of very difficult graphic to show, but it's again highlights some of the challenges that we have in Africa, and in particular in Cameroon, with sewage leaks and dumping of waste being a common urban environmental hygiene problem in Africa and in particular in many parts of Cameroon as well. So we have to improve the quality of our water quality and achieve our workaround towards improved dumping and sewage disposal, which is still a very significant problem. You might remember, Mr. Chair, several months ago, we had Mr. Quinn Gopte, who talked to us about the ECO project, the WASH project with sanitation in Africa, which was a really great presentation where he talked about water, wash and sanitation in what he's been doing in Cameroon. I thought that was a very exciting presentation. I do encourage you all to go back on maybe on our YouTube page and try to watch that video where he made a presentation of the state of this project in Cameroon and what they've been doing to advance sanitation practices in Cameroon and across the world. But there's a lot of promise in the utility of wastewater. This is again a graphic from the US that shows just highlighting the rise in wastewater levels in the last several weeks. You can see those levels have sort of been rising lately, and these levels sort of correlate with what we see in the hospitals. With slightly, you can see the rise in COVID-19 new hospital admissions has also been rising concurrently as the COVID-19 levels, SARS-CoV-2 concentrations in wastewater has been rising. So people have been able to sort of model wastewater concentration levels with hospitalization data and sort of created some sort of models that best represents concentrations in wastewater. This is a very, very difficult subject because it's something that there's just so many metrics that we have to account for. The weather can affect what the concentration of a virus would be in a fecal sample. The time of the day when you collect the sewage sample also matters, could also affect the concentration of wastewater. There are just a variety of factors. So just taking one pinpoint measurement of wastewater sewage site it's just an estimate. It just gives you one snapshot view of what might be circulating in that population, but it's incredibly difficult to make sense of wastewater concentration at this stage of the pandemic. So I think it's an area of it's an area that requires a lot of research. It's an area that I think we need to have more standardized methods in terms of controlling for some of those variety of or multiplicity of factors that could influence those wastewater level. There's a very brilliant scientist called Dr. Whelan, who has tried to do just that. He's tried to recently tried to create forecasting measures where he looks at wastewater data from BioBot and has tried to model what the case counts might be in the community based on the concentrations that you're seeing in wastewater, which I think is quite remarkable. And his model kind of works. It gives you a very good and decent representation of what might be happening in the community. And that's what we need. So because we want to understand what these levels, this rise in COVID-19 levels actually mean. And finding some very rigorous methodological approaches that expatiates on that is very helpful. So I definitely recommend you read more about Dr. J.P. Whelan's modeling forecast, and you'll learn a lot from him. I think the approaches he has taken is quite innovative, and I think he's one of the first people I have seen that's really made enormous progress in terms of creating this correlation between wastewater levels and community transmission. There are other useful things you can do with wastewater as well. Based on wastewater data, you can also have an estimate of what the circulating variance is in a sample. And very important for me to highlight here that wastewater it's a mixed sample, so it contains sample from an entire community. It's very difficult to build a whole genome sequence based on wastewater sequences, sequencing what you find in wastewater alone, because you have a mixed sample. So you can have multiple spikes from, could come from multiple people. It could come from one person who's been a chronic shedder, etc. So it's very difficult to actually do a whole genome assembly from it. But based on the constellation of mutations that these individual Omicron subvariants have, it can be possible to distinguish just based on the spike alone, to distinguish and say this is an Omicron sublineage. This is BA.1, this is BA.2, BA.2.2, etc. So it's been possible for us to distinguish different Omicron subvariants based on the mutational profile alone that we find in wastewater. So that has been our easiest metric. And here in the US started shipping home testing kits. Once the US started shipping home testing kits, antigen-based testing kits, we sort of lost our ability to keep track of what the case count in the US is, and I think it's very difficult. So most of us have to rely on the genomic sequencing data from wastewater, which is extremely nuanced, and still trying to figure out how do we make sense of this data, how do we correlate whole genome, how do we correlate sequencing data from wastewater with clinical or whole genome sequencing data in order to have a better estimate of what's happening in the community. But also more importantly, the constellation of mutations you find in wastewater, what are the clinical and therapeutic implications of those variants, right? So those are some of the key questions that are important as we move on into the pandemic. It's more about if the emerging variants have properties that would evade the vaccines that we currently have. Do they have properties that would evade the monoclonal antibodies that we do have? Do they have therapeutic implications? Do they have clinical or more severe clinical implications and things like that? So I think that's one metric that we should be tracking and keeping an eye on as we evolve throughout the pandemic. This is a table that from the World Health Organization, again, that shows just the proportion of circulating Omicron subvariants within the epi week from 28 to 32. And they've been tracking this for, like I said earlier, for the 28-day epidemiological reports from the WHO. And you can see the EG.5 subvariant has been the predominant variant, at least in the last 4 weeks, followed by the XBB.1.5 XBB.1.16 and then the XBB.1.5. So those has been the predominant variant that we've had, not only globally, but even here in the United States as well. Those has been the predominant variant. And these ones have been labeled by the World Health Organization as variants of interest. These are variants under monitoring, like the BA.2.75, the BA.2.86, which I'll talk about in a bit, and other subvariants. So just tracking and keeping an eye on what's circulating in the US is kind of critical as we move on throughout the pandemic. The number of as testing numbers has gone down, it's also incredibly difficult to keep track of sequencing data because we get sequencing data from cases. So if there's not a lot of people testing, or if a lot of people are getting sick and not going to the hospital and just home testing, then it's incredibly difficult for us to actually have representative sampling for cases circulating in the population. So most of the sequencing data we obtain are from hospitalized patients, not from people who have an acute infection, maybe subclinical infection who've gone to the hospital. So it's become incredibly difficult to keep track of what circulating variants is. So the graph on top right here, the first panel right here shows the significant decrease in the number of sequences that have been submitted to GISAID. GISAID stands for the Global Initiative for Sharing All Influenza Data, and it's been a very rich source of information regarding SARS-CoV-2 sequencing data, and that's where everyone in the world submits their sequencing data from. And you can see the number has just been declining and declining and declining worldwide, and in particular in the last few weeks. So without enough sequencing data, it's very difficult. It's very difficult to know how the virus is evolving and things like that. Incredibly difficult. So and I'm not sure how else we can keep track of this. We probably have to figure out ways to alternative measures. We have to think about more innovative techniques to maybe to reconstruct phylogenetic trees to have a better sense of what variants might be circulating and things like that. And the graph below just shows the proportion again of those Omicron subvariants. So you can see EG.5 is quite a fair chunk here. We have XBB.1.16, XBB.1.9 that have been circulating. So the genomic data is important, but for it to be actionable for public health, it needs to be done quickly, ideally in real time, and it needs to integrate data from multiple sources, and this should include clinical data and epidemiological data. The genomic sequencing data without the epidemiological context is meaningless. So we need to use that data to drive public health actions and things like that. And there's a great need and a great void in terms of bioinformatic analysis and the ability for applied epidemiologists in the field to be able to use these tools and interpret these tools and make meaningful recommendations to policymakers. So I'm going to shift gear a little bit to talk about this is a phylogenetic tree that highlights the current subsampling of all SARS-CoV-2 sequences from the last several weeks. So this next trend build highlights the evolutionary dynamics of SARS-CoV-2 sequences that have been uploaded on GISAID, and you can see right here, these are some of the Omicron subvariants and things. This is the Alpha variant, the Beta variant that we had before, the Delta variant, etc. So those have, so a phylogenetic tree really shows you how cases are related to one another and kind of shows you the ancestral, how it has evolved from the ancestral strain up to this point. So if you look closely here, there's kind of like two dots here. They sort of overlap, so it's a little bit difficult to see, but I'm going to amplify this in the next slide, but showing the emergence of this new variant called BA.2.86, which I'm going to talk about in a bit. But this kinds of phylogenetic analysis is really crucial because it gives us a sense of how the virus is evolving. And I think every individual country should at least keep track of the genomic surveillance of their variants so we can see how the virus is evolving. But more importantly, if the variant in your country is accumulating mutations that have clinical or therapeutic implications that the world should know about. So here's a zoom in view of that BA.2.6, which again just appeared out of nowhere. I think the first initial cases were reported out of Denmark and has a wide constellation of mutations that hasn't been seen before. So it's antigenically very distant from the B2 polyotomy. So that's one of the reasons why it's driving concerns, because of this concept of convergent evolution, where you're seeing reoccurring mutations that you had previously seen with maybe previous variants like Delta or Beta or etc. So having some sort of convergent evolution, and most of those mutations are antigenically distant. So there's a group, J.C. Bloom's lab, whom I have lots of respect from the Fred Hutch Cancer Center in Seattle. They have been able to map out some of those mutations and map out those ones which have therapeutic implications, those that have immune escape properties. And this is just a graphic that shows which of those ones have, whether it's antibody escape or enhanced ability to bind to the ACE2 receptor, which is the receptor that the virus uses to get into the cell. So the virus has evolved to become better at infecting cells and has sort of evolutionary adapted to being able to evade our own immune response, whether it's immunity derived from vaccine or from prior infection, etc. So the J.C. Bloom's lab have really done a great job in terms of mapping out what the mutational profile, what the implications of those mutations look like. So this is a slide again, still from the J.C. Bloom's lab, where he gave us a little background on the BA.2 variant. So BA.2.86, which you might be hearing about a lot because it's been rising a lot. But more importantly, it has the kind of mutations that we saw early on in the Omicron wave, how Omicron just diverted from Delta very quickly. So the constellation of mutations in BA.2.86 is a very wide divergence from what we've seen previously among other Omicron subvariants. And that's one of the reasons why it's garnering this much attention. But it's very important to just keep a track of it. So this is a graphic visualization of what the BA.2.86 looks like. You can see it has really diverged from that BA.2 polyotomy of variants. So and it's been growing and spreading. There are not that many cases yet. When I checked early this morning, I think there were about 73 cases of BA.2.86.1 across the world, and about 29 cases in GISAID. So I think altogether they are close to about 100 that are either BA.2.86 or descendants of BA.2.86. So it's very important to keep track of this and just to monitor how they are close. And you can see the total number of mutations that they do have that separates them from that underlying polyotomy right there. And what's even more interesting here is the large number of scientists and groups and scientific laboratories that have been doing research to look more specifically at the implications of these mutations on BA.2.86. So these are just screenshots from preprints that were released in the last few weeks regarding BA.2. This is the graphic from Yunlung's lab. I think Yunlung is in China. And what he did here was he tried to look at the antigenic distance for Omicron for BA.2.86 in comparisons with other Omicron subvariants, and found out that it was antigenically very distant from XBB.1.5, but what he found in his lab was it did not increase the level of infectivity compared to other Omicron subvariants, which I think was a good sign. So it might be very efficient in transmission, but not very efficient in terms of evading. It might be very efficient in terms of immune evasiveness, but not very efficient in terms of transmission. There was another group. The second group here is the Murers group. This is from the Karolinski Institute in Sweden, where they found similar results, where they tried to look again at the neutralization titers for against XBB.2.86 in comparison to BA.2 and BA.5. And you can see again the overall immune evasive properties kind of decline for BA.2.86 compared to the others Omicron subvariants. So that sort of confirms what Dr. Yun Lung saw in his own lab. These are other preprints that have also come out that have showed, again, the decrease in terms of immune evasive properties. Again, these are pseudo assays, so these are not human results. These are recombinant spike protein that have been studied in the lab and then trying to measure what their rates are, either using convalescent plasma or neutralization titers on people who've been infected and trying to model that against the different pseudovirus titer. But I think what was the most impressive, what I found most impressive was the study from Baruch's lab. And Baruch's lab is, I believe, in Boston, maybe Harvard, I can't remember, but he showed the decrease in the total. He showed the first thing he did was he tried to map out all the mutations that were present in the BA.2.86 in comparison with the Wuhan strain. So here's a comparison with BA.2, here's a comparison of BA.2.86 mutation compared to the Wuhan strain, which I thought was a very phenomenal view. And also he tried to map out all the mutations that you see on BA.2.86 in comparison to XBB.1.5. XBB.1.5 is relevant here because there will be, yesterday the CDC the FDA, was supposed to approve was supposed to meet to discuss about the booster shot for the fall. And that booster shot is going to contain the XBB.1.5 variant. And the CDC is supposed to meet next week to discuss about who is going to be eligible to receive that booster, etc. So it's very relevant to compare this relative to the XBB.1.5, just because that's what's going to be contained in the monovalent vaccine that's going to come out. But I found this mutational mapping, very interesting from the Baruch lab in comparison to the others. And one of the things that he did in his study was he also tried to measure the neutralization antibody titers for different, not only BA.2 and XBB.1.5, but he compared the neutralization titers against the Wuhan strain BA.1, BA.2, BA.5, as you can see right here, which was quite fascinating. But what was quite interesting here is the unlikely dissociation between new mutational load and the magnitude of immune escape. So that was so on the flip side of this, you can think about it as there was a relative lack of immune escape, as you can see, characterized by the graphic here. And this is kind of relative to the EG.1.5 variant that I mentioned earlier is slowly becoming the dominant variant, and also you can see the decrease in terms of neutralizing the FL.1.51 variant as well. So I thought that was a very interesting result from the Baruch lab. This preprint was released, I think, yesterday, and it showed this was the first time they actually looked at the clinical trial using actual patients. So these were randomly selected patients who received the monovalent Moderna XBB.1.5 booster. And here they tried to measure what the levels of the neutralization antibody titers were. And they found out that overall, it had significant protection against BA.2.86, which I think is a very good sign as we get into the summer. So that's it about the BA.2.86. I think based on the data that we have and all the studies that I just showed you with neutralization antibody titers, the fall booster is very likely to still confer protection against all the Omicron subvariants. But getting infected with COVID is still one of the problems we have not been talking a lot about is about long COVID, the people who still have lingering symptoms from long COVID. This is an article that was published in Nature late last year that really showed, that assessed the risk of COVID-19 sequelae among those with COVID-19 infection, with or without, those with infection with and without reinfection, and also those who have been vaccinated, either no vaccination, with vaccination, or more vaccination. And what they overall found was that vaccination sort of conferred protection against post-acute sequelae associated with COVID-19 infection. So this whole concept of long COVID, this concept that people get infected and they have lingering symptoms that persist long past for months, long past their infection, whether it's brain fog, fatigue, breathing difficulties, muscle pain, things like that. So this, they found out that those who had received their vaccination, their complete series of vaccination, had much more lower risk of getting long COVID than those who did not. And you can see that again, still really well highlighted in this graphic here as well. So preventing infection is probably our best bet in the first place, so we don't have to deal with the sequelae that comes with COVID. And this is a slide from borrowed from Dr. Mona, but here he showed he tried to highlight the Swiss cheese respiratory model, that there are different layers of protection that can really help us to prevent COVID-19 from mask or staying at home if you're sick, etc. So I think this Swiss cheese model still applies not only for COVID, but even for other respiratory infections like RSV and flu. Still very important to take very personal responsibilities for your own protection when you go out, and depending on what's going on in your own local community. The current strategies for combating COVID-19 hasn't changed. It's still the same thing. We still need testing. We still need therapeutics. We need vaccines. We need those to come out quickly. So the same control measures to prevent infection are still the same. Not much has changed in that domain. In terms of therapeutics and treatment and just the clinical profile of the disease, the recent COVID-19 variant are not causing as much severe disease anymore. And this could be for a variety of reasons. It could be just be the fact that we have much more herd immunity, whether it's from infection or it's from a natural infection or it's from vaccination, etc. But the level of severe disease has significantly decreased for a variety of reasons. But it could also be that the new Omicron subvariants do not have the kinds of mutations that causes them to bind very closely to the ACE2 binding receptor that facilitates the entrance of the cell of the virus into the cell and having enhanced viral replications and things like that. So very important to keep track of those as well, treatments and management considerations for the different subtypes. COVID diagnostics hasn't really improved. The algorithm is still the same. This is the IDSA, the Infectious Disease Society of America's algorithm for diagnosing SARS-CoV-2. Much hasn't really changed in that domain. The only problem here is not enough testing, so it's again very, very difficult. Many people who are infected have very subclinical symptoms or maybe asymptomatic altogether, so not a lot of testing, but the algorithm hasn't really changed that much. Also, there's serological testing recommendation that has been issued by the Infectious Disease Society of America, again, that quantify antibody levels. We are still not at a stage where we can really tell with certainty what the correlates of protection is. There's a lot of correlation between what the levels of neutralizing antibody titers are with protection from SARS-CoV-2, but it's still not very clear what that threshold is and how that threshold varies depending on the emerging variants and things like that. So it's something that's very difficult to track and to keep on our radar as the virus continues to evolve and change and things like that. So serological testing is important, quantification, but how making meaning of those numbers is also very difficult. There was another paper, I believe last week or 2 weeks ago, that showed that binding binding antibody units may be even be a better correlation of immunity or protection than actual quantification of neutralization antibody titers. So there are some studies that have looked into different antibodies levels and things, but overall, they found out that the higher your neutralization antibody titers, the higher your level of protection from several of those measures. In terms of COVID-19 treatment, nothing much has changed. Some treatments, most of the monoclonal treatments obviously are not working because the virus has changed and altered its surface antigens in such a way that it's very difficult for those monoclonal antibodies to work. So there's currently no monoclonal antibody that really works against COVID. So if you have non-serious COVID, or non-severe COVID, the standard of treatment is maybe Paxlovid within 5 days of being infected. So, but unfortunately, those treatments are not widely available. Like in Cameroon, in Africa, they are not still widely available, which again is a very, very big global health problem that we still have to have conversations around. But Paxlovid has been very effective. Paxlovid right here has been very effective in terms of preventing progression to severe disease. Concerning management of hospitalized cases, again, dexamethasone has been very effective, particularly for people who are hospitalized requiring oxygen and those who are on mechanical ventilation or ECMO. The recommendation still is against the use of dexamethasone for those who've been hospitalized and who do not require oxygen supplementation. So otherwise, most of this information has changed. Just one last comment about molnupiravir, which was a really great oral antiviral, but unfortunately there are studies that have shown that it could be accelerating the rate of mutations in SARS-CoV-2, so could be responsible for a fair share of some of those mutations that we see in emerging variants. So there's been some recommendation from the IDSA, the Infectious Disease Society of America, and also the NIH to use Paxlovid, and only if the patient is not able to take Paxlovid, to recommendation for molnupiravir. But I don't think it's a recommended treatment anymore because of some of the reasons that I've highlighted. But also the IDSA has made available a whole guidelines on treatment modalities, which I won't go into. But the treatments and therapeutics are still the same. These are just a screenshot of some of what those treatment modalities are. But not much has changed. So I still recommend, always talking to our healthcare talking to your healthcare providers and about what the best therapeutic for you would be, depending on the clinical situation. But I think what's even more important for us is how do we make available these therapeutics in Africa, because they're extremely expensive, not only here in the United States for the common US person, but also how can we make this more accessible and more available in our own local context, in our own country, in Cameroon, in Africa, and things like that. So I think we still have a long way to go in terms of making those possible. So those are the little slides I had to share with you all today. Thanks a lot for listening. Just to highlight that the pandemic is not over, even as much as we want it to be. We want it to be over. We still have to keep our radar on in terms of pandemic preparedness. We don't want to be taken by surprise by something that pops out of nowhere and things. And as you know, climate change is continuing to have a significant impact on. We want to keep track of all the things that are evolving in both animal reservoirs, in the environment, One Health, etc. So the niche or the distance between humans and animals is getting closer and closer. And I think it's important for us to heighten our surveillance mechanisms and be able to be in a position where we are able to track what's circulating in the community and figuring out what the easiest methods to do that is. So thanks a lot, and I look forward to any questions you might have.
Wow. This is great. Thanks so much, Bryan, for this wonderful presentation. It's really been a classroom session for some of us to really get these updates and know exactly what's happening. If you don't mind, you can stop sharing your screen so we get everybody to the screen and get on with the interaction. I mean, that's so you showed some very interesting figures there that one could not imagine that we still have 9-point-something million cases of COVID in Africa. That's really, it might look small on the table when you present it, but it's very significant when you come to think about the fact that a lot of people had forgotten already about COVID. So it's really, your presentation is really an eye-opener that it's not yet gone, and we still have to be vigilant. Hello, Dr. Mono. Some thoughts on the presentation.
Yeah, Elvis, this is brilliant presentation, Bryan, and it highlights a lot of very interesting things I always said during the pandemic. It showed to us that even right now, even as much as the Western world has moved ahead and we have had a lot of discoveries when it comes to effective vaccination, some therapeutics, those therapeutics are still not available in most parts of Africa. Most African countries cannot boast of even having Paxlovid if they have a pandemic. Even remdesivir, which has been there for 3 years, molnupiravir, access to tocilizumab, access to baricitinib. And there was an article that was released. I think the activists actually won in court by taking Pfizer, Moderna, Johnson & Johnson to court to release how much they sold the vaccines to African countries, especially South Africa. It was scandalous.
Yeah.
I don't know if any of you read that. I saw that on one of the publications on Dr. Boguma's page. It was scandalous knowing that we in Africa paid more money for this vaccine than those who were living in first world countries. Meaning they had a better deal. And so solidarity, public health solidarity is still a big problem. I think this pandemic has taught us that we have not improved since the flu pandemic of 1918. There has been no change. Then we had very little resources. Now we even have more technology, more resources, but there is no global collaboration. There is no global, how do they call this? There's no real consideration for those who are poor. And for whatever reason be it, Africa did well. That could be a debate of a whole century of how this worked, but we should not let our guards down. So Bryan, thank you for this wonderful presentation. I have some few, not questions, but things I want us to reflect about when the time comes. Elvis, over to you.
No, excellent, Mono. And I think that's why one of the drives of the African CDC now is to encourage local manufacturing in the continent so that we can be able to get ownership over what we manufacture and supply and be ready for the next pandemic, which of course might not be now, but will soon one day still happen. And when we also talk about this, it's also important to encourage local scientists, African-based scientists, to also research and discover their own molecule, because I think if just the fact that most of these companies will have to hold tight to their patent before they ever release most of this to be produced in the generic form is still a big handicap, even if we have the capacity to manufacture. So there's a lot of debates on just how much we need to do at the level of the continent to get prepared for the next pandemic. We have the pleasure today to have Professor Matthias Fobi, who is also on the session. Welcome, and some words from you about the presentation.
Oh, thank you very much. I joined kind of late, but I'm impressed with the statistics. I thought that we did not have that amount of disease in Africa, but that's a lot of people. So the points are well made. We need help, and the foreign governments are taking advantage of us. And all I have to say is us and our children to make the difference in the future, because we have to address issues in Africa. And what the previous speaker said, we have to start producing our own medications, and as scientists have to start looking at developing their own drugs. But again, a very enlightening presentation. I'm glad to join you. I've been away for a while. And believe it or not, it took a while for me to join because I had to go through a lot of credentialing to reconnect. I don't know what you did. I hope you did not change it because I had to go through 3 credentialing to get back on Zoom. So make sure that people don't miss because of difficulties logging on. Again, thank you for the presentation.
Yeah, thank you very much, Prof. And thank you for letting us know that. I think we'll have to speak with our technical department and see if there might have been a glitch, which we are not aware of. But if others really also witness similar situation, we deeply apologize and we'll try to find out what happened so you don't have that challenge next time. And thank you so much, Prof, for your comments. I think it's really important that we continue to try as much as possible to be self-reliant at the level of some of these basic public health needs that or challenges that we face in Africa. We have Dr. Judwin from the UK. Tell us the situation. Have you been seeing some cases as a pediatrician in the UK? Dr. Judwin, are you with us? Okay, she might be in the listening mode. And so let's also get, I'm just choosing some random people to get some comments. We have Dr. Gima Mofo. Any comments about the presentation? All right, and then let me get to Dr. Samuel. Dr. Samuel, welcome. You are a regular. If you are speaking, you might be on mute.
Oh, yes, thank you very much, Elvis. It was a wonderful presentation and having excellent updates from Bryan. Bryan, you do, as usual, and excellent work. Getting all those details is very helpful, especially for those of us at the front line knowing what is happening. We already know in the Dallas area that we're having a rise, and getting all this up to date is really helpful. And to add to what Mono said, thinking about back home, the challenges that we're facing back home, not having access to even just information, and coming to the town hall all the time, it's just always been very educative for me. And I can't wait for the question and answer session to ask some few questions. Thank you.
Great. Thank you. Thank you so much for always tuning in. I know even when you are not on the computer, you use your phone. Thanks so much for being a fervent participant of the Cameroon Town Hall. Before we get to the chair, I see his hands up. Let's just hear from Stefan Biheng. Any words from you about the presentation?
Yes, very good presentation. I really like it. I just had a question. It was from the beginning when Bryan, you talk about wastewater treatment, and I wanted to know how long the COVID or the new variant can live in that wastewater. So because you mentioned that it was something that could really help preventing also contamination. So how long do a virus like the COVID virus will last we survive in the wastewater?
Good question there for you, Bryan. Maybe you take it before we get to Mono.
Yeah, sure. Thanks a lot, Stefan, for the question. It's a very important question. What you find in wastewater is nucleic acid material. It's not an actual virus isolate. So a wastewater sample is a mixed sample. It's really a fecal material mixed with a lot of other things, chlorine and lead and other things that people typically use. So it's the level of the nucleic acid that's actually being quantified. Yes, you could potentially find or isolate live virus from wastewater, but it's also that's really not the goal. The goal is really to disentangle the entire nucleic acid for the specific virus. Look more specifically at the spike, because most of the wastewater surveillance systems are tracking more specifically the spike, and conserve regions within the spike regions in order to quantify what the levels of those are. And obviously, when you swallow your own respiratory secretions, you know, it has to go through your GI tract. The enzymes and all the enzymes there as well will have an effect in terms of the survivability of the virus itself. So most of the time, the virus might not be live by the time it leaves into your fecal material. But there's been research that has demonstrated the isolation of live virus in fecal matter. But in most instances, it's really the isolation of the nucleic acid material by PCR that's useful for tracking what the levels or monitoring what the levels of wastewater is in region. But one other point has been the aspect of people who are chronic shedders. There are people who don't really succeed, people with different kinds of immune suppressive disorders who don't really succeed in clearing the virus after they've been infected. So they have most of this virus still lingering in their system, and they shed this virus to their feces and things like that. And having to track those as well in isolation is quite a big challenge. So wastewater is a very difficult pool in terms of isolating individual virus isolates in general. But tracking the nucleic acid concentration is the way to go.
Great, and Mona, you can take it away.
Oh yeah. So thank you very much, Bryan, for this wonderful presentation. My first kind of question or for us to reflect about is in Cameroon in particular, I don't know about all African countries, sewage disposal and the way we do treat our sewage. Is that even a method which we can use to survey COVID? Like, let's say Cameroon, we mostly have individual sewages in houses. We do have pit toilets. Is there a way of us using soil sampling around those pit toilets or individualizing different? I don't know exactly if this methodology that is used in the US is something that we can actually use. Is there something else we can think about? A way of us trying to track and to understand the prevalence of the different variants that could be going on in Cameroon and other countries. I know watching Cameroon right now, most likely the data is showing that there are few or no cases around there. But if we start having cases, what do you think we can do in terms of this? Because it looks to me already like a very difficult thing to do in Cameroon. And the next, I would have two for now. Question is, how Dr. Fobi was talking about the solutions. How do we, as Africans, prevent all what has happened in this pandemic by buying vaccines at a cost which is super more expensive than everyone else bought, by us being taken advantage of by a lot of pharmaceutical companies, because now all the secret documents that were kept have been released. And we do know that South Africa paid more for the vaccine than the United States and European Union. South Africa even paid more for Johnson & Johnson vaccine that some of them was even not retrieved from the market at a certain time. And they had clauses that they had to pay the whole money for everything before they even got a supply. This is more of a kind of health economic question. How do we leverage as Africans, get to a point where we can sit on the table? I think most of the solution is for us to improve and create our own drugs, but how do we do that and how do we get to that point? What are your reflections about that? Those are the two questions for now, but I have other ones. I think this is just for everyone to give their insight about it. So Bryan, over to you.
Yeah, I would love to hear insights from others on the call as well on what Cameroonians and Africans can do to do this. There's been a call for transfer of technology in terms of the messenger RNA platform, for instance, in Africa, those advances. But I think Africans we have to come out with local solutions to our own local problems. We have to build our own expertise around everything, around bioinformatics in terms of vaccine developments, and not rely a lot on the West. So I think it's really important for us to develop the skill sets we can, or learn as much as we can from maybe from the West, but also really come back home and really implement some of those things. So the transfer of technology is really crucial, but also we really need to build the capacity locally among our own scientists and be in a position where we can develop some of those vaccines and therapeutics and things like that. We are not there yet. It would take a concerted effort from every African Union member state. It needs political ownership from the individual African Union member states. The presidents and governments need to take ownership of this problem and be committed to this particular cause. So I think that's the only way. If government don't take ownership of this problem, we'll probably be in the same place 20, 30 years from now.
Regarding Bryan, before you move to the next question, just so we stay in line to that, respond to that question, one of the contributions I want to bring also, Bryan, is that there are some areas, and I'm trying to follow up the South Africa case and actually study how the procurement was made. And one of the things I think that add to cost, unit cost of procurement for most African countries is using third party for procurement. And I want to see if that was the case in South Africa. And why do governments choose to use third parties? Why do governments not buy directly from manufacturers? It comes to the point of challenges in currency transfer from most countries out of their country. And you are in a pandemic, and you need to transfer funds to Johnson & Johnson to get vaccines. And the government mechanism and processes are so complex for that to happen. Then you are forced to look for a third party who are supposed to use their own funds and procure those things and supply to government, and then follow up for payment for whatever time government is going to take to pay them. All those are things that add to cost for a lot of some of the commodities. Because if you look at pricing for most commodities that are not manufactured in Africa, and you look at the prices for which some of those governments buy those things compared to the manufacturer's price, there's always a big layer of additional cost, which is just because of the use of third parties. So I think it also has to do with the procurement process of which most countries are using. And I'm sure I'm going to dig to know exactly the South African case for the vaccine to see exactly if it was a direct government procurement or if it was a third party procurement.
Yeah, it's very unfortunate what happened with South Africa. I think that's just, it's unforgivable. I think with the leadership of the African Union member states, I hope we get to a better place where we can resolve this in a sustainable way for the future.
Yeah.
Thanks.
You can take on his second question was about the context of the sewage management in Cameroon and how that can be a challenge in terms of just tracking the surveillance, as you mentioned. Or any comments about what Muna said for that?
Yeah, I think that has to go in synergy with our own sustainable development goals around just making sure that development locally, honestly, because even the slide I showed you was from an urban setting in Africa, in Cameroon. So that was a graphic from, I don't want to call the name of the city, but that was a graphic from an urban area. So we still have very inadequate sewage disposal methods. Pollution is still a problem, just dumping things here and there and stuff. So it's something that would still require synergy with other aspects, other parts of the SDG goals, the UN SDG goals for our individual countries. We have to build better sanitation and wastewater treatment plants and things like that. We are not in that place yet. A few weeks ago, the Scripps, I think the Africa CDC got some fund. Well, the Scripps Institute in the US got some funding to help develop wastewater analytical pipelines for Africa. But my question or worry is, how is this going to be implemented when we don't really have robust wastewater treatment plants in Africa? So it's going to be difficult, Dr. Mono, to answer your question. I think we can only get isolated samples from individuals' homes, but we don't really have a system that links different households, because that's the entire concept around wastewater treatment plants here in the US. We have households that are kind of linked with these treatment plants and pipes and things like that, and you can get an isolated sample that represents or pseudo represents an entire community. So I think we are not there yet. I think as we align more and more with the other sustainable development goals, and again, this is an area where I feel that the government needs to take complete ownership of the problem to address this together. So it will transcend into other aspects, it will transcend into public health, it will transcend into other domains as well. But those are my thoughts. I don't think we're there yet.
No, thank you very much. And you remember we had launched a series on some of the social determinants of health, and I think we will be bringing in experts from other sectors that do not represent, that is not directly healthcare, but that have impact in the things that happen in the healthcare space. So we have Samuel's, and that is all.
Hello. Yeah, thank you for giving me the opportunity to ask a few questions. Just to add, we're talking about, like Bryan really said, we need African solution for African problems. And of course, I think this is an eye opener. And as we continue to advocate, I believe that it's all left to us to continue to do our own share. And Bryan, the question that I have two questions. The first question is, I'm sorry I joined late. Was there at a certain point, especially in the US, that we could say we got to the herd immunity, either through vaccine or being infected with COVID? I mean, like, was there, based on data, was there a particular point, and I know we've had multiple different variants of the vaccine, of the COVID. That's my first question. That based on what you know, was there a particular point that you could say we had a herd immunity before the pandemic was over, and what was that percentage? And then my second question on serology. Is there a minimum titer for the antibodies, the titers that you can say when if you do a test, you will say you are immune? I know I heard you say it is very difficult, but at what minimum titer values can you say based on the antibodies you are immune to be infected?
Good.
Yeah, those are two very important questions. Did you want to say something, Elvis?
No, I was handing over to you.
Yeah, those are very difficult questions and also very complex questions, particularly the question around the correlation between neutralization antibody titers and what protection is. Obviously, we've seen that levels of neutralizing antibody titers sort of correlate with, immunity, and it sort of wanes with time. So once a person has gotten a booster, the levels of the neutralization antibodies sort of declines over time. And the more it declines, the more they are more susceptible to, to another infection. And this is particularly for people who are much older, like 65 years and older, or people with other comorbidities or underlying medical conditions and things like that. So that correlation has been evident, but it's still not very clear what the exact correlates of protection are. We can see these correlations between neutralization antibody titers and protection at certain points, but it's still very unclear what the defined correlates of immunity means. For other infectious disease, we have very clear correlates of protection or correlates of immunity, but for COVID, it's been very, very difficult to pinpoint what those levels mean, what the IgG levels mean, or what the IgM or concentration of IgM levels or IgA, which is also another part of the immune response, which we don't talk about, the mucosal, the role that mucosal immunity plays in terms of preventing infection in the first place. So the IgA levels, IgM levels, IgG levels, what those concentrations mean moving forward, very, very difficult to to pinpoint and to say what that is. So it's a very tough question, and I don't think we are there yet, as we have been for other infectious diseases. But back to the first question about herd immunity. Still, again, very, very difficult, particularly in the context of a virus that's evolving this rapidly and changing and constantly accumulating mutations that have properties of immune evasiveness. Very difficult to really pinpoint what that herd immunity threshold is or would be. Because as we evolve in the, throughout the dynamic of this pandemic, the constellation of mutations that we see rising have properties that either enhance the ability to infect cells or get into the cells much easier. It's very difficult to say we've reached a certain point just based alone on what neutralization antibody titers is, where we can say this is herd immunity. What the United Kingdom did, and the European CDC on April the 27th.
Bryan, you're having an echo. I don't know why.
Yeah, I'm not sure why that's happening.
Okay, but that's fine now.
Okay. Yeah, so what the European CDC did and the UKHSA, it's like the Ministry of Health of United Kingdom, did on the 27th of April 2022 is they declared a state of endemicity. This wasn't like a threshold for herd immunity. It was rather, they looked at the level of COVID-19 hospitalizations or hospital admissions and deaths, and they found out that it was comparable to the levels of hospitalizations for RSV, respiratory syncytial virus, and flu, and they decided to declare a state of endemicity at the time. So that was just really based on what the case levels were and what the hospitalization risks are. That's how other public health agencies have done it across the world. But I think in the context of COVID, it's really very difficult for us to tell what that is. Hopefully, if we had something as a really well-defined correlate of protection or immunity, it would be a lot easier to answer those questions, but I don't think we are really there yet.
Thank you very much. Just a follow-up question. With multiple mutations, do you think that we're going towards basically like influenza, where we might end up vaccine would depend not just having a booster, would just be like what we're doing with the influenza vaccine?
Yeah, I do suspect that we will definitely get to that point where we might have to have regular boosters every year, just like we have with the flu. That's my suspicion. I'm not an expert in the vaccine development, but I do suspect that that's going to be the case. If you look historically or in retrospect at what we've seen with other variants, it seems like the emerging variants tend to evade immunity from infection with previous variants, or even evade immunity generated by vaccines of other strains. Like we had the BA.4.5 bivalent booster that had the Y type and had the BA.4.5, but still the level of neutralization antibody titers was low with the emergence of new variants. So I think we have to figure out a way to enhance surveillance for new variants. One Health is going to be very important, tracking how the virus evolves in animal hosts, in the environment, etc. So we can keep a track of the constellation of mutations that are emerging and what the correlation or what the clinical implications of those constellation of mutations is. So I think that's probably the biggest thing we can do, just to track what that is, to map what those mutations are, and to hopefully have a better estimate of what their immune evasive properties are, and probably just design vaccines based on that.
Thank you.
Elvis, I think you're muted.
Thank you. So I was just saying that the floor is open to anyone who wants to ask a question or make a contribution. You can just raise your hand up and I will give you the opportunity. And before I get back to Mono, Bryan, let's talk a little bit about testing. And we know at some point in time in the peak of the pandemic, Kenji will do his presentation and so we can test ourselves out of the pandemic. And testing was really a very important element during the fight against COVID. And we went to from just testing through PCR to rapid diagnostic test. And at some point, there were even tests that were mailed to people's homes to help them be able to self-test and all that. At this point in time, where's the place of screening for COVID or self-testing or rapid diagnostic test? And as we're having the progression and mutations and everything, is there some follow-up on the sensitivity of all these tests that were developed earlier, or are there also innovations in this space? Can we still think that those tests are still very sensitive enough as they were during the peak of COVID, or is there something that needs to be modernized or revamped in the area of testing?
Yeah, the good thing is the antigen-based testing, which have not been affected with the emergence of new variants. Usually, those target. I think Dr. Kenji talked about this. Those really target the conserved parts of the virus. So the part of the virus that's less susceptible to that's less antigenic, so less likely to elicit an immune response. So the conserved regions of the spike regions is usually what's the target for both PCR and also for antigen-based testing. So those have not really been significantly affected. So the tests still hold their value. But the bigger question is, what is the value of counting clinical cases at this point of the pandemic? With the level of immunity that we have at this stage. There was an estimate, I think, from the CDC a few weeks ago that showed something like 95% of the US population has either been exposed to COVID or has immunity either from COVID infection or from vaccination. So again, what is the meaning of counting new cases and things like that? How do we keep track of those who are doing at-home testing and things? So it's very, very difficult. So the innovation of wastewater is probably the closest metric that we have in terms of assessing what might be happening at the community level.
Good. How about you, Mona?
Yeah, Elvis, thank you. So here I just had a lot of my question to Bryan is looking at the BA 2.86. Do you think we are close to having a new variant altogether coming out soon? Like we've been having, Omicron has lasted forever. So my question is, the way things are moving, you are one of those who have been studying the genomics of this disease for quite a while. Do you think that we'll get to a point where there's going to be a whole genetic drift or shift in such a way that we'll be able to have a new variant in this disease? The question is when and what direction do you think is going to go? Is it going to go towards this direction that we're seeing right now? I know it's a question really for anticipation, but just something I wanted to talk about. The next thing is concerning vaccination. I've had patients, this is real life story. I've had patients who have come to my office. We are hearing over the news that the number of cases are rising. Doc, are you going to advise me to get the vaccine that is available now or to wait for the new booster? That's a practical question. I had this question yesterday twice from two of my patients. I will not tell you what they have because they can be identified by that, because some people know where I work. So they did ask me. One was a believer in vaccine, wants to get any vaccine whenever it's available, but wants to know if she should go get one now or she should wait for a booster to be out, which the CDC is working on getting a license on. And the second one was someone who is actually not a big believer, but wants to measure his or her risk, depending on those who have had side effects from vaccines, if she would likely die from the vaccine or die from the cancer. So really, these are two questions. I don't want to make them long, but I have a lot of them concerning COVID. I've not been as, I know I used to follow COVID a lot. I've not been as frequent with COVID, but I want to get my updates today.
Mara, those are very pertinent questions, and I wish Mokuma will be an excellent person to address the last two questions that you had. I think yeah, those are really great and pertinent questions in terms of who should the vaccines be targeted for. I think the CDC ACIP is meeting on Tuesday to discuss about this. I don't know what the recommendations is. I suspect it will, based on the data that we have, it's likely going to be recommended for people who are 65 and older and those who have underlying medical conditions. So based on that, I think that's probably what the recommendation would be for specifically for those high-risk groups, and not for the general public. I don't know if I would recommend someone, you know, maybe it should wait till the XBB.1.5 monovalent variant is available, because it has more coverage for the virus. But I think that would be an excellent question for someone like Dr. Bogomati Tanji to address at this point. Regarding the really first question on the emerging BA.2.86, we haven't really had another variant of concern after Omicron, another letter designation, and because the BA.2.86 really diverges from within the BA.2 sublineage, so it's not a very distinct lineage like Delta or Alpha or Beta or Iota or one of those other Greek letter variants. So it's difficult. All the sublineages currently circulating in the United States or across the world are to an extent all divergent from the parent Omicron lineage. So that's why we haven't really heard about any new letter designation of that sort. And all the Omicron mutations are still very similar. Several of them are antigenically distant from each other, but they are still very, very similar to one another. So not a lot of change in that domain. And I do not foresee that the World Health Organization is going to designate BA.2.86 as a variant of concern. Probably will continue to be monitored unless it has some very significant changes that may affect hospitalizations or has very significant clinical implications. I don't think or foresee that will be the case. Those are very different questions.
Yeah, thank you very much. I know there were tricky questions. That's why we're here. And some of them do not really have a fixed answer to it. And Elvis, can I follow up? It looks like
sure,
I'm very interested in COVID. So
we're having a conversation here. So anyone.
Yeah, we're having a good conversation, which I think, as I said, I told a lot of my patients, if you're above 65, I think you should have it. And it really depends on what kind of cancer I was treating. Those who have B-cell lymphomas that we're treating them with rituximab, most of the time the vaccines have not been very effective, and we're looking forward to new monoclonal antibodies and other things to replace Evershield that we used to give these patients to prevent them as soon as the pandemic starts surging. So there are other tools. We have toolboxes. We have, other than vaccine, that there are some subgroups that may not effectively mount an immune response towards vaccination. So I'm really taking case by case, but there's my general approach really right now to my patients who are above 65 and sick is, and critical is for them to get vaccinated and to follow the guidelines based on what CDC decides. And so rather waiting or not waiting is some of the question which I cannot answer right now based on the data I have. My next question really comes with long COVID, and the second part about it is going to be testing. Really, the question for long COVID is a very complex and confusing concept. Why? Because it's been difficult to even understand these patients who are talking about long COVID. Is it really long COVID? Is it an anxiety issue? Are we dealing with people who have other things going on that they're confusing for long COVID? And Bryan did present us a lot of data about studies that have been done in Europe, studies that have been done in the US. So really, how do we, going forward, get to a point where we can do good research, good surveillance, and monitor long COVID in such a way that we can really comprehend what this was and what this means? Did we miss an opportunity, Bryan? My next question is, oh, I'm echoing now like Bryan. So my next question goes with the fact that we are not doing enough testing. And we are relying a lot more on hospital-based testing. What percentage of hospital-based tests are being sequenced? Because if I can recall, in my former hospital where I used to work in New York City, every patient, my new hospital, I don't know exactly how their testing is. Every patient who gets into the ER, even up to now, still gets a COVID test, like it's standard. Everyone who walks into their ER gets a COVID test. So in that aspect, though it's not going to reflect you cannot generalize testing sick people in terms of public health because it's going to be skewed. The fact that they are sick, they are more likely to have COVID comparing to the general population. But is that some data that we can use as a means of surveillance if all hospitals are doing that? I don't know what's happening in Nebraska, but this was just in New York City. I think they still have a mandate of testing everyone who gets into the ER, just to make sure that they are able to isolate them and do other things. So thank you. Those are my two little tips to get this discussion going so we can better understand what is going on.
Moro, you're asking very tough questions. So yeah, your questions are they're very important, very pertinent, but also very, very difficult to address. I lead the genomic surveillance program for the Midwest in the US, and that covers most of the states in the Midwest. My general recommendation is for us to sequence everything that is sequenceable. The problem with hospitalized patients is they have very, very high CT values in most instances. So a CT value or cycle threshold is the number of cycles a PCR machine has to cycle for you to have a detectable signal. So if the cycle threshold is very high, it means the viral load is very, very low. And if the CT value is very low, the viral load is very comparatively very high. So cycle threshold for people who are being hospitalized for COVID in most instances is above 30, usually 35 and above. And it's very difficult to get complete genomic sequencing data from people who've been hospitalized, chronically hospitalized. So it's a waste of resources to really sequence samples that are above 35. It's very expensive for us to do it, and also we don't really gain much because most of those sequences fail anyway. So not a lot of surveillance is happening at the hospital. We try as much as possible to sequence everything. That's what I do for all the for those in the region. But we've been leaning more and more towards wastewater to see what's happening. So wastewater surveillance gives us the best estimate of what is happening at a community level. The other thing we pay attention to is what's happening in long-term care facilities and nursing homes and things like that. So if the rates of hospitalizations of sick people within nursing homes is rising, we also track those very closely. Those who live in nursing homes just have to be routinely tested frequently, every now and then. So that's also a good thing. We don't, they are just required to be tested every now and then, so we can get a sequencing data from those groups of people as well to have a much better representation. But again, those are very important questions. I think it's going to be extremely difficult for us to have a better sense of what is happening at the community level if we don't have enough testing going on. Like I said during the presentation, we've lost our ability to count cases and to make meaning of incident cases. But I also think incident hospitalizations is probably the best way to keep track of where we are in the pandemic. So just seeing the levels and how the levels of hospitalizations or hospital admissions that are due to COVID, not by COVID, not with COVID, like you go get tested, you go for your cancer appointment, you get you get a nasal swab and you're positive for COVID, therefore it's a COVID-19 hospitalization. No, actual COVID-19 hospitalizations is that where that distinction is being made, and we are doing our best to try to make that as standard as possible. So yeah, I think that's it. The other part of your question, I think, is about vaccination. I think is very complex. It would be a great question for Bokoma to answer.
Great. Ladies and gentlemen, thanks so much. We've had a very interesting conversation with Bryan. And Bryan, thank you so much for putting this very excellent slides together. We've learned a lot. It's been a learning session for a lot of us who had kept COVID already at the back of our mind. That has kind of rekindled our knowledge again and brought the all the updates fresh into our mind. Just a reminder that we need to still keep reminding ourselves that it is not over yet. It's been a great session. Looking forward to see you guys again next week. Let me just give a round of turn to Bryan to say some last words before we hand it over to Mono to end the session.
Thanks, Elvis, and always great to have you. I really appreciate the opportunity to talk about this. Really great work. I think we still have a long way to go in Cameroon and in Africa. We really need to. Just last week, the Africa CDC released what started the Africa CDC Epidemic Service, or which is similar to the US CDC Epidemic Intelligence Service. And the goal is to train applied field epidemiologists. So we really need to build those sorts of capacities, have field epidemiologists that have the skills to rapidly respond to epidemics and outbreaks as they arise. So capacity building is really important. We need to have the skill sets to be able to do those kinds of things. We need the technological infrastructure to do these things. We need to have the machines and have the ability to use them. Many of our institutions in Cameroon do have those sequencing machines. For example, I'm just giving sequencing machine as an example, but the ability to make sense of the sequencing data is still a challenge. The bioinformatic capacity that is needed to process the data is still very lacking. The skill sets and all that, all the processes that goes into it is really lacking. So we really do need a lot of capacity building and training and everything in order to get us to a place where we can function. So I think we conclusively we need African solutions for our own African problems, and I think that would be the way for the future. So we start on the
Great. We kind of lost you during the few last seconds of your conclusion, Bryan.
Oh, sorry about that. I just concluded by saying we need African solutions to African problems. We need to rely on ourselves, build the tools and skills sets that we need for sustainable solutions to our own African problems. So that's what I think, and we need to make more progress in that in building those sorts of capacity and not have to rely on the West or other countries. We need African solutions for African problems.
Great. No, thank you, Bryan, for the excellent presentation and for your very powerful conclusion. We'll get to Mono for the last words before we end the session.
Yeah, Bryan, thank you very much for rekindling this reason why we started a town hall on going back to COVID. It's very important for us to really reflect on what our lessons have been throughout this pandemic, which I think it's over but not over. We're seeing that we're going to live with this. It's going to become an endemic situation. It's going to become something similar to what we deal with the flu in the Western world, but this is going to be either in the Western world or in the rest of the world. We'll have to learn to deal with this. We are still learning a lot, despite the fact that we're 3 years and some months into the pandemic, we're learning a lot. I think we're learning that new variants are going to happen if we keep surveying them. We're learning that we need to be on top of it. We need to build our surveillance system. We have learned a big deal as Africans during this period that we need a lot of solidarity. We need to stand together. We need to reinforce our scientific and research collaboration within African countries and with the West. We have also learned that South Africa did a great job by discovering a lot of the virus. And we think they can set an example to us also. We can also lead to development of medications that can be effective for this pandemic and future pandemics. So there is still enough to learn, enough to say how we're going to survey this going forward. A call for boosters, a call for what type of boosters to get, what is the meaning of long COVID, how are we going to deal with this going forward? Is it going to be a new kind of persistent rheumatological disease that is going to linger with us post-viral? We have to still figure out testing, the best way to do it. Even in Africa, is it something we should be doing always? Is that where we should tally our limited resources to? So, and thank you. And we do know that the most effective drug against COVID, severe COVID, is very cheap. And I just want to make sure that everybody still knows that dexamethasone is cheap, is available for those who are on oxygen. Don't hesitate to start them on it. While we're thinking about getting things like baricitinib, tocilizumab, molnupiravir, remdesivir, and the Plascovid, we need to know that we do have some tools. And I think this pandemic has really helped Africa and Cameroon in particular reinforce oxygen availability. As Dr. Yauba and the Clinton Foundation will tell you, they did a lot during that period. A lot of hospitals that never had oxygen do have oxygen. A lot of the healthcare workers know the appropriate ways of using this oxygen and escalating oxygen care, which there is also oxygen plants that have been built. And a lot of units in Cameroon actually got equipped with intensive care capacity to intubate patients. These are all positive things that came out of this pandemic. And we did have also, as Kenji would say, PCR machines were made available that we can now use for other research. It's a machine, PCR, you can do a lot of other things with it. So I think always coming back to COVID after a year of not talking about COVID is a wonderful thing. So Bryan, thank you very much. Thanks for the brilliant presentation, and thanks for making us rethink about this COVID problems and see how we can go forward with it. So Elvis, over to you. I just enjoyed it so much. I learned a lot. I didn't ask questions on the things I was learning. I was taking here is my little book. I was taking notes. So,
yeah.
So thank you.
No, thank you so much, Mona. It's been a great opportunity to listen to Bryan today again and to get some of these updates on COVID. Thank you so much, ladies and gentlemen, for tuning in for this session. Hopefully, we should be seen again in a fortnight for another session. I want to thank all those who have stayed until the end, and to thank our presenter for his time, and of course, our chair for his leadership. And Mona, I know we were supposed to meet and I was going to Colorado. I spent 8 hours at the airport yesterday to be told my flight was canceled. So that's why I'm here now. See you soon. I know you're in New York. The cat out of the basket.
Yeah, so